So, guys, today we are going to be talking about TLC and DLC, and the idea is to make you interpret TLC and DLC, that is leukocytosis, neutrophilia, neutropenia, and also to recognize lymphocytosis and eosinophilia. Sometimes they have very important diagnostic meaning in the ICU. So just a short video, and I think you'll find it very useful. So let us start with this case here. This is actual case in our ICU, and this patient presented with this kind of a TLC and DLC. And he was paralyzed, GCS was 4-5, and this was the CT. So everybody thought he was a young patient, 25 years old, male. And everybody looked at this and thought this was a stroke in young, and the TLC was high because there was an infarction, and nothing much else was thought about it. So I came the next day and I looked at the reports, and what do you think here now? This is there in front of you. Do you think this is just a stroke or this is something more? So here is the importance of looking at the DLC. So if you look at the DLC, the lymphocyte count is 50%, which is above normal. And you see, if the absolute lymphocyte count is more than 4,000, then it is called lymphocytosis. How do you calculate absolute lymphocyte count? So here you take, for example, in this, you take the lymphocyte percentage in the DLC. So here is 50. So it will be 50% of the total leukocyte count, which is 12,000. So it will come to 6,000. So here the absolute lymphocyte count is 6,000. And if it is 6,000, it is more than 4,000. So the patient has lymphocytosis. Now, when you come to lymphocytosis, there are very few causes. And very important amongst them is viral. So viral etiologies should always be considered when you have lymphocytosis. And then there is leukemia. So leukemia, you have to recognize and pick up. After that, this goes to the hematology oncology. And the other important cause is drug hypersensitivity reactions, which come sometimes. Sometimes the history is not very clear about drug hypersensitivity. They are having multi-organ failure and they have a rash and they have fever. It looks like some kind of an infection, sepsis. So that also has to be recognized. But this, if you know this, if you know the causes of lymphocytosis in terms of viral, leukemia, drug hypersensitivity, which contribute to 90% of lymphocytosis. There are some other causes, but the idea is to give you a holistic approach and tell you the main stuff so that you are competent to deal with TLC, TLC. And the other point I'm trying to drive home here is that lymphocytosis has to be picked up by looking at DLC. People in the ICU don't look at DLC, including in my ICU. Everybody just looks at TLC. TLC is normal, increased, or decreased. Here you have to look at the DLC. Unless you look at the DLC, you will never pick up lymphocytosis. You will never pick up eosinophilia. I will show you about eosinophilia in the coming slides. So this patient had a viral infection. We investigated, we kind of examined the patient, there were other features, and he had infectious mononucleosis. Nothing much could be done. He had a very massive infarct because of internal carotid artery vasculitis and thrombosis. So that was it. By looking at the lymphocyte count, we were able to diagnose and we were able to prognosticate and tell the family. Otherwise, it becomes very difficult why a 25-year-old healthy guy has suddenly collapsed and gone into GCS 3-4 with such a big stroke. Now coming to TLC and DLC. So you should have an idea of what the normal counts are. So here neutrophil, you see bands, lymphocytes, eosinophil, monocytes, and basophils. So neutrophils and eosinophils and basophils are also together known as granulocytes. Sometimes you must have read granulocytes. So what are granulocytes? Neutrophil and eosinophil and basophils. Now what are bands? So bands are immature neutrophils. And they should not be more than 4%. There are other kinds of immature neutrophils also, like promyelocyte and myelocyte, etc. So sometimes you get a report shift to the left, that there's a shift to the left in your TLC, DLC, right? What does this mean? So this is having the same meaning as neutrophilia. So the total counts are same. There is shift to left means that there's increased immature cells in the neutrophil series, and this has to be interpreted in the same way as a neutrophilia. Okay, but one has to make sure they are not excessive blasts. Normally, the lab will not report like that. If they are blasts, they will report blasts. Blasts are never seen. There are no normal blasts in the peripheral smear. If they are greater than 5% blasts, that means that patient might have a leukemia. Now, apart from all this, monocytes really don't have too much of a significance to an intensivist. Neither do basophils. Basophils can be elevated in anaphylactic reaction. So there the anaphylaxis is obvious. So basophil also don't mean anything, but eosinophil has diagnostic connotation, which I shall explain to you. So this is another patient here. Now here, TLC is 1500, DLC is normal, and the blood pressure is low, temperature mild, SATs low, creatinine 2. So what is the first diagnosis? First diagnosis is sepsis, right? Okay. What else can it be? Can it be anything else? So it can be many other things. It can be cardiogenic shock due to MI, it can be pulmonary embolism due to right ventricular shock, right? It's possible. So when the patient comes to you in the ICU with the elevated TLC, how often are you right in saying that this patient has a sepsis or he has an infection? So the stats say, this is from the journals, 1 out of every 3 patients admitted to the ICU with increased counts has a non-infectious etiology. So if you look at the counts, and the counts are high, and you say that the patient has sepsis, you're going to be wrong in 33% of the patients. One has to have a broader outlook and try to think about the other possibilities. The way I think is, when the TLC is elevated, I don't think it is sepsis. I first think what else it could be and try to rule out. And then I think of sepsis if everything else is excluded after looking at the history and examination and whatever reports the patient has brought to the ICU. So coming to the causes of neutrophilia, that is the elevated TLC count. Now, other thing is, if the TLC count is elevated and the differential is normal, what does that mean? So that means it is neutrophilia, right? Like I talked to you about DLC. So here again, we have this question of DLC. If the TLC is elevated, but if the DLC is normal, what does it mean? It means there is neutrophilia, and these are the causes of neutrophilia relevant to the ICU. So sepsis infection is the leading cause, and then we have SIRS like in pancreatitis, polytrauma, burns, and other conditions. Then steroids. So steroids are very important, guys. I want to tell you about steroids. Patient may come with steroids, right? Sometimes they shift it from outside hospitals, and it's very common, at least in the smaller ones, to give a shot of steroids or a couple of days of steroids. And the moment you give steroids, your TLC goes up, there is neutrophilia. If you give a shot of steroid in the morning, your TLC will go up in the evening. And either the patient gets the steroids outside and comes to you, and the TLC will then be elevated because of steroids. There may be another reason. He may be having sepsis also causing an elevation, but this is a confounding factor. You have to sort it out. And the other thing is in the ICU. In the ICU, practically 50% of the patients are getting steroids. You have COPD, you have asthma, you have sepsis, you have pneumonia, you have ARDS. Everywhere the patients are getting steroids, right? And like I told you, once you start steroids, you'll get neutrophilia, TLC will go up, and this will increase for a couple of days and then stabilize. And after you stop steroids, it does not come down immediately to normal. It decreases a little, and then over the next few days, it kind of normalizes. So this is very important. Whenever you are confronted with an elevated TLC, look at the drug chart for steroids. You will find it very frequently. That may or may not be the only cause. So if there's something else happening, like I told you, that also may be causing an elevated TLC. Then we move to infarction. So myocardial infarction, pulmonary infarction due to embolism, brain infarction, they all cause elevated TLC. Then inflammation of any sorts, epinephrine injections. So if you give a bolus, like in a cardiac arrest situation, you will have elevated TLC. If there is acute stress, adrenaline will be secreted and you will get high TLC. Then alcoholic hepatitis is very important. People are drinking all the time and we get all these cirrhosis. So alcoholic hepatitis comes to the ICU frequently as acute on chronic liver failure. And these patients very often have elevated TLC lasting for a long time. If this stays, this elevation of TLC stays for 2, 3, 4 weeks. So don't think the patient has an infection. You have to look at the trends of TLC. If the TLC is like this and it shoots up, then of course there's a problem. So the trends in TLC are also very important. And one should also look at CRP procal at times when one is not able to make out from the TLC. Now moving on to DK. DK patients have a elevated TLC and don't think this is an infection. So don't start antibiotics in DK. DK patient may get an infection or may come with an infection which precipitates the DK, but TLC per se can be high because of diabetic ketoacidosis. Then poisonings because of the stress. Many poisonings come with elevated TLC. And after splenectomy, sometimes we do splenectomy in the ICU because of trauma, and or maybe he may be shifted because of surgery due to some other reason into the surgical ICU. Then for 2-3 weeks, you have a elevated TLC and elevated platelets also. And this is because spleen is the site of removal of leukocytes as well as platelets. So when the spleen is removed, the increase in numbers in the circulation for a couple of weeks. And finally, there's a vast list in hemonc. Hemonc has so many causes, so that is not in our area, but this particular list should be known to you as a cause of neutrophilia. It's very important because once you know this, then you can figure out why the patient is having neutrophilia and one can diagnose the condition. Now, coming to leukopenia. So leukopenia is not that common, but it is common. So again, the patient comes to you with the isolated leukopenia, right? One of the common causes is drug induced, but these cases are not common. What is common is sepsis. Again, sepsis becomes very common, and then we have infections like enteric fever with complications or tuberculosis or certain other infections. Even rickettsial diseases, scrub typhus can have a leukopenia. So you have some infections, viral infections can have leukopenia. Then, like I told you, drugs are an important cause of neutropenia. Any drug practically, there's so many drugs, it is not worthwhile talking about the drugs or giving you a list. Many drugs can cause. So one has to take the drug history and see. And this kind of leukopenia responds well generally to stopping the drug and giving GCSF. Then HLH may have bicytopenia or pancytopenia. And HLH has many causes. It can be due to primary HLH, it can be due to viral etiology, it can be due to connective tissue disorder, it can be due to a malignancy. And HLH, there will be bicytopenia or pancytopenia, and there will be multi-organ failure or single double organ failure. And HLH is a serious condition. And splenomegaly, because spleen removes white cells. So if the spleen is enlarged, you'll have excessive removal of white cells. Autoimmune diseases can have leukopenia. Then extracorporeal circuits are important. You get leukopenia after ECMO, you get leukopenia after CRT, you can get leukopenia after hemodialysis. So hemodialysis is a transient phenomenon, it goes away within hours after hemodialysis. But CRT and ECMO go on for long times, and you can get persistent leukopenia. And now this is because of contact with the surface inflammation and consumption to some extent of leukocytes and sequestration, etc., of leukocytes. Basically, contact with the circuits that the leukocytes come in touch with. And what happens now if the patient develops sepsis in this? What will happen to TLC? So it is very variable. Either it can remain normal, or it can decrease, or it can increase. So again, one has to look at the trends, and one has to use CRP and procal at times to kind of figure out this and look at the clinical picture. And then finally, again, you have hemonc conditions. Now, if the patient is having absolute neutrophil count of less than 500, then the condition becomes serious. Beyond 500, that is, if it is more than 500, then it is not so much of a problem in terms of getting an infection or what is called a febrile neutropenia. But if the ANC is below 500, then it kind of becomes serious. And whether you should give antibiotics here or not depends on whether there's an infection, which may manifest with fever or may come with the signs like chest infiltrates or pain abdomen or some skin ulcers or skin lesions. So one has to look at the patient clinically, but one should have a very low threshold for giving antibiotics. And antibiotics have to be determined by the flora of your ICU, and antifungals are also needed at times if the infection is not resolving in 4 to 5 days. The other thing is the use of granulocyte colony stimulating factor, GCSF. So GCSF stimulates the marrow to release neutrophils, and 5 to 10 microgram per kg is the usual dose. As a single dose, you give it normally, and you keep giving it till the counts go up to 10,000. All patients of neutropenia do not respond to this because leukopenia has varied etiology. But if the marrow is good, like if it's caused by drug suppression or chemotherapy induced leukopenia, then these respond well to GCSF. So you give it till the count goes up to 10,000, then you stop it. And the other thing is you have GM-CSF also, granulocyte macrophage colony stimulating factor, that also behaves more or less in a similar fashion, but this is more widely used. So that is about leukopenia and its causes. Now we come to the other condition, eosinophilia. So here you look again, TLC 9000, neutrophil 45, L30, and E15. So if E is 15, what is the absolute eosinophil count? So it will be 15% of 9000. Okay, so that will come to something like 1100, 1200, whatever the calculation is. And absolute eosinophil count more than 500 is called eosinophilia. So eosinophilia again has diagnostic connotation, and unless you look at the differential count, you will not pick it up if you look at only TLC. So what are the causes? Important causes are allergic reactions, which can be life-threatening anaphylaxis or even severe asthma reaction or whatever, any kind of allergic reaction can cause eosinophilia. Then worm infestation and parasites. So this can be lethal at times. Do not think that worms and parasites only cause OPD problems. So I have seen a patient of strongyloides, and the strongyloides was disseminated throughout the entire body. The patient was having, weight loss and decreased appetite going on for 2-3 months outside. He was showing outside in the OPD, etc. Then he started developing shortness of breath. He was admitted to the ICU, and we, upon investigation, doing a BAL, we got OVA of strongyloides, and we investigated further. The entire body was infested with strongyloides. And similarly, you can have these worms traveling through the body, going into the lungs, causing pulmonary infiltrates, even hemoptysis, hypoxia. So they can cause a lot of problems. They go everywhere depending on what kind of a worm you are dealing with. So it's very important to pick this up. And eosinophilia is very important. It is present in 80 to 85% of these worm infestations. It may not be there all the time, but if it's really bad, it's generally there. And then there are primary hypereosinophilic syndromes, and sometimes you have certain vasculitides also which have eosinophilia. Now, just to give you an idea about certain points regarding TLC, DLC, I have explained to you neutrophilia, leukopenia, leukocytosis, eosinophilia, and lymphocytosis. The importance of looking at DLC and not just TLC. So it's very important, and I've given you the conditions also. If you know this, you know 80%. Okay, rest 20% you can read up, or as you grow older, you will get those 20%. And they are not that important also because sometimes we have to call the physician or the primary team, and it's up to them to make these rarer diagnoses. But what I've told you, you should know. This is the crux of TLC, DLC. Now coming to pulse, I told you 1 out of every 3 patient who comes to ICU will have a non-infectious cause of increased TLC. And if it happens in the ICU, only 1 out of 2 will have a cause which is infectious. So it's very important to realize that. Dehydration is not a cause. So if you get dehydration, we know there's hemoconcentration. The hemoglobin level is falsely elevated. But that is not the case for TLC. TLC never rises because of dehydration. It is a misconception. I've heard many people saying that because the patient is dehydrated, so the TLC is high. That is incorrect. And if you want to understand it, if you take a glass and if you put hemoglobin into it, hemoglobin is 50%. So if the volume shrinks of the glass, obviously the hemoglobin concentration will go up. But the amount of space occupied by WBC is much, much less. So even if there's a shrinkage in the glass, in the volume, it does not affect the TLC concentration, white cell concentration. Now, sepsis may have increased normal or decreased TLC. And there's a condition known as leukomoid reaction. Now, sometimes the patient has 70,000 count suddenly, and you're not sure what it is because 70,000 is like a leukemia. But this can happen with a infection also. And this is called a leukomoid reaction. So how will you make out? Just simply. So you order a peripheral smear and ask the pathologist to look for toxic granules or DOHLE bodies, DOHLE, DOHLE bodies. And when the pathologist looks at the peripheral smear at the neutrophils, if he is able to identify toxic granulations, that means it is an infection and not a leukemia. Very simple test. Then elderly and immunosuppressed patients may not develop leukocytosis when challenged with fever, infection, sepsis, etc. And viral infections, though I told you about lymphocytosis in that particular patient, they can have a variable TLC and DLC. You can have sometimes leukopenia, sometimes you can have leukocytosis, sometimes you can have lymphocytosis. So it's variable. It's not necessary that viral infections have lymphocytosis all the time. Then leukemia is diagnosed if 5% of TLC are blast cells in the peripheral smear. And then, of course, you can do the marrow and all those things. That is another thing. This is just to give you a simple statement. In the peripheral smear, lymphoma is a histopath diagnosis after biopsy because lymphoma, leukemia go hand in hand, and often the counts are elevated in these conditions. And lastly, a very simple statement, smokers can have a mildly elevated TLC. 12,000, 13,000 TLC is consistent with chronic smokers. So I hope I was able to convey TLC, DLCs to you, and you got the hang of it, and you'll be able to approach TLC, DLC in a much more consolidated fashion with more understanding and able to diagnose the conditions on the basis of the TLC and DLC. And I want to thank you with this last slide, the famous picture of sunflowers, rather the painting by Van Gogh, which hangs in the museum in London and is one of the most expensive paintings in the world today. Thank you so much, folks, and hopefully we'll be able to move on to better and better content. I hope you're enjoying the channel, and I'm trying to make it better and better. Any questions, any comments, feel free to put that up in the chat box. I'll be happy to answer them. Take care. Bye-bye. Take care.